Today, I would like to speak to you about radiosurgery for treatment of benign tumors. It was a very kind invitation in his hot topic series, where Dr. Guilherme Cassia asked me to talk about benign tumors and malignant tumors. I will introduce some of the concepts of radiation and radiobiology, already explaining a little bit how we treat these tumors and bringing a little bit about the mechanisms of radiation to treat benign and malignant tumors. And then I will have a full lecture about only malignant tumors. Now, I will speak to you about the benign tumors, meningiomas, acoustic neuromas, and pituitary adenomas, which are really the bulk of the benign tumors treated with radiosurgery and also with surgery. The other ones are less common and are also treated with radiosurgery, but I will not comment on them today. And I will have some conclusions where we are in terms of treatment of these tumors with radiosurgery. First of all, I would like to call you the attention for integration. Today, we integrate technology of a MRI in the operating room with a hybrid surgery, which I will explain to you. And we complete treatments with the gamma knife and with the cyber knife, depending on each one of the indications. We integrate as well and neurosurgery throughout Brazil with our large group that belongs to Neurosapiens now. It's a group that works together to treat the patients throughout Brazil with high technology and always in a collaboration, in discussions that make us do the best we can for our patients. I want to give you first an example of the power of radiation on these tumors, single dose and fractions of radiation. We use both of them, very much directed to the neuroscience to understand the radiobiology of these tumors. Here we have an example of this young boy with a tumor that would lead him to have a enucleation of his eye, and we treated him with radiosurgery, fractions of radiation, and we were able in less than 2 months to make this tumor completely regress and preserve his vision. So this is important that the public knows that when you use the power of radiation, very focused, not in the spreading radiation throughout the brain, but very focused to the tumor in a single dose, we have an effect in the DNA that makes you possible to treat several pathologies in the brain. And I will discuss with you here the benign ones, and then I will discuss later on the malignant ones. I will start with the meningiomas, which are one of the most common tumors in the brain. And we have a large number of them treated with surgery and radiosurgery in the team that I worked for 30 years at UCLA. Commenting on the doctor now, the neurosurgeon now of the future, this is becoming clear that one person alone cannot have it all for himself, but he has to treat patients in a multidisciplinary team of radiologists, neurosurgeons, radio-oncologists, physicists, oncologists, and I put here et cetera, but in reality are the group of collaborators that are necessary to treat these patients with very complex diseases. It's very important that we understand, as I mentioned in that rhabdomyosarcoma, what's happening in the molecule of DNA. This molecule is beating us here now, not only with tumors, progression of diseases, diseases that are hereditary, diseases that are infectious diseases like the COVID, that we still need much to understand how we can affect this molecule to treat very difficult diseases. For instance, depending on the doses we use, we can increase growth factors, we can produce neurotransmitters in the brain. Here, for instance, with the tyrosine hydroxylase, serotonin, glutamate, and when we affect these molecules, we can treat different diseases, such as the neurodegenerative diseases, vascular diseases, tumors, and we can make the nervous system suppress, for instance, epilepsy and pain, and even obstruct vessels in case of vascular malformations. We also can, in the next lecture that I will speak with you about the effects of radiation in malignant tumors, how we can stimulate, for instance, with the abscopal effect, the system of the immunology against the tumor. So it's very important that we understand this tool in depth, because it has a major effect on the treatment of patients. Here we have ionizing radiation working in the molecule of DNA. You can use it very high doses to destroy, or we can manipulate the function of the brain with proper doses of radiation, not very high to destroy, but to obstruct vessels or treat the metabolism in pituitary tumors, changing the quantity of hormones, the malignant tumors, epilepsy, as I mentioned to you, making the channels of the membrane to be suppressed, and so on and so forth. Open the blood-brain barrier, very important in the treatment of patients that need chemotherapy and even immunotherapy. So the new concepts of using radiation, using precise, focused radiation to treat tumors, it's very important. Radiosurgery is what we call with a single dose of radiation, strict precision. This is 0.3 millimeters in precision in delivery. So we have indeed a very precise as a knife in the hand of a surgeon. And then we have the stereotactic radiotherapy. The radio-oncologists like to use long fractions, or now they are being convinced that less fractions are more effective because we can indeed, with the precision, avoid the complications that radiotherapy used to give in the past. So I will discuss with you all this based on an experience of since 1986 at Harvard University, where we trained how to do radiosurgery. And throughout the years until now in the Redidor San Luis, where we are treating with a gamma knife and with a cyber knife, but we had already had those experiences in the past with older machines, and now we have the most modern possible machines, and also with a linear accelerator, now the true beam, which we work as well, making centers throughout the world. Going directly to meningiomas, I want to arrive to you and talk a little bit the importance of radiosurgery in meningiomas. That's a very important help that radiosurgery came for the neurosurgeon. It's not a competition, it's a help to the neurosurgeon. Obviously, a tumor that can be completely removed, including with a Simpson grade 1, it would remove the dural attachment, this patient will be cured. There are tumors in the periphery, in the cortex, even those attached to the sinus, sagittal sinus. We recommend resection before radiosurgery because the results can be sustainable and with less complications. However, when we arrived in the skull base and related to important nerves, radiosurgery becomes a very important and even a protagonist in the treatment of these tumors. If you see surgery in general, this is the great Simpson classification of surgery. If you completely remove, we still have recurrence in 9% of the patients. Mind you that with radiosurgery, tumors well located, we can do better than this 9% here. Well, complete resection with cauterization. coagulation of the dura, then we arrive here to 19%, and then the recurrence becomes higher, and it can be at 50 to 90% in the grade 3 and grade 4. Therefore, these patients do need help with radiosurgery. If you look at one of the major neurosurgeons that has an extensive experience in treatment of meningiomas, we see here Dr. Al-Mefti, his results, grade 1 and grade 2, that we have here 76%. With a complication of death, 1%, 1.5%. This is possible in any surgery. Serious complications, this is hemiparesis, lower cranial nerve deficits. We can have at 5% almost, and acute complications such as infection and CSF leak is also an important number. So surgery in these areas is not to take lightly. When we look at these tumors, we classify them. This is in the early, it's 20 years old classification already, grade 1, 2 to 6, that depending on the involvement of the tumor in the skull base, growing from the cavernous sinus, expanding to the clivus, compressing optic structures, compressing the brain stem, having bilateral involvement of the cavernous sinus that becomes a very high grade, as well as the optic sheath meningiomas. So we can treat those patients with radiosurgery and with stereotactic radiotherapy. Radiosurgery we have here in red, stereotactic radiotherapy, hypofractions or full fractionations. We treat these tumors, more complex tumors. So grade 1, we see here a very well located tumor in the cavernous sinus, treated with a good response. And then we have here a clival tumor, a grade 2, already arriving close to the brain stem. And then we have those involving the optic apparatus. And here with fractions of radiation, you can see you can improve vision over the time. I have the follow-up of this patient now more than 20 years that I treated this woman, and she has a better vision. She had lost one eye. She had only half of the vision in one eye, and you could recover quite a bit of this last eye she had in a tumor located in the tuberculum cell involving the optic apparatus. And more extensive tumors, this here is still a grade 3 involving the optic apparatus and extending up after resection. We can treat these tumors with quite a bit of long follow-up. These patients respond quite well. I'll show an example of these with more than 20 years follow-up controlling tumors. This the grade 4 tumor that already has a good compression of the brain stem. And the response of a grade 1 single dose, 2004, 2012. Here we have a major decrease in size of this tumor in a 78-year-old woman. Here is a tumor that I treated in 1992. She had already an operation that was not effective in removing the tumor. As you can see, this is impossible to remove without causing the patient a lot of deficit. The patient left without almost no deficit, had a Karnofsky of 90, had a little bit of loss of sensibility in the face and dizziness. We treated this with stereotactic radiosurgery then, 12 gray, and we follow her from 75 until 87 years old in a great quality of life. So this is important that we use this technology to give people good quality of life without causing neurological deficits. Long-term follow-up of these tumors, the tumor control is very high. The skull base much more than in convexity. This is statistically significant. And these tumors already follow for more than 10 years. This is important when I look at the long-term follow-up of these patients. This is our patients, all of them involving the cavernous sinus. And here we have a tumor control of 98%, cranial nerves improvement. It improves the cranial nerve with stereotactic radiosurgery, stereotactic radiation, and the tumors decrease in size. This is not quite the goal. This is the goal, improve the patient's quality of life, right? Well, similar data now with microsurgery. Same patients looked at in Lyon, France by Dr. Sidou, the group of Dr. Sidou, a mortality of 5%. So this is not something that we can think that's not a serious surgery, microsurgery, and they can arrive to the conclusion that there is no significant oncological benefit in performing surgery in the cavernous sinus. So these tumors are really today accepted to treat, being treated with stereotactic radiosurgery. If you look at a long-term follow-up, you look microsurgery here, you see that with microsurgery, we don't have 10 years follow-up in the literature almost. When you look at the literature of radiosurgery, gamma knife and fractionated, yes, you do. And you have there 95, 97%, 80%. So it is a very high control rate on these meningiomas with stereotactic radiosurgery. So the complement of stereotactic radiosurgery is extremely important in patients that have grade 2 and grade 3, grade 3 and grade 2, 3, and 4 Simpson resection. The decrease of the tumor can be substantial, and the deficits in microsurgery, 20% almost of deficits of cranial nerves here, while with stereotactic radiosurgery, this falls quite a bit, almost half of the complications. And the follow-up, really long-term follow-up, we have more in the group of radiosurgery. In the past, we had in surgery, but if you look at the literature, these patients are not followed seriously in the long-term time as it is with radiosurgery, because radiosurgery requires a long follow-up with imaging. So it's very important that we see results like a single dose, fractions of radiation in our cases, 135 cases, which you compile, 94% control, long-term follow-up. So this is an extremely important result for stereotactic radiosurgery. Do we need to enter in the cavernous sinus to know what the tumor is? No, we can go through the foramen ovale. We reported this with Dr. Frigueto, Brazilian neurosurgeon that studied with us at UCLA, and we can make the diagnosis of what it is and treat these tumors with a good result. The biopsy was made. Then the stereotactic treatment of meningiomas was said in the past. There are people that say that causes malignancy. That's not true. We look at our data in 52 patients. Dr. Matoso studied with us. He reviewed all the pathology with the pathologist at UCLA, and we see that indeed some cases they would get malignant without radiation, and actually this was not completely significant after radiation. So there is no evidence that radiosurgery causes malignancy. There are relates of case reports in the literature, but not in a series that has become anything as significant. Benign tumors, grade 1, grade 2, and grade 3 in our cases. You see that there is the quality of results that you have over time. Modern surgery. Modern surgery now, this is a meningioma, is in the this is a meningioma in the pontine angle. However, you can partially remove this knowing what you are doing, a 72-year-old patient, and maintain this patient intact. So now during the operation, we can check what we are removing with neuronavigation, and you see that the brainstem already moved into the cavity of the tumor. So this is not tumor, but it's the brainstem. This is a pre-imaging, and now post-operative imaging, you see that the brainstem already moved into the space, and we left a bit behind this particular meningioma. You are still following it. We haven't yet offered stereotactic radiosurgery. And we can, with adaptive hybrid surgery, really see well in details what we can do and what we cannot do in terms of cranial nerves. Here, decompressive surgery becomes important. You see, this is an optic sheet meningioma. Actually, it's a meningioma that had been operated on 3 times elsewhere and came to see us, and the tumor was now penetrating in the orbit fissure. It's not a meningioma from the optic sheet, but penetrating the optic sheet and compressing the vision here in the canal. You see that the left worse than right. We worked first decompressing the right side, and then we took him to decompress the left side, and we had already some improvement in this patient. He used to see only volts. Now he can see fingers, so he's improving, and there's a surgery here happening. You see that there's a very small incision, always minimally invasive. There's a 3 centimeter incision in which we go to remove completely the clinoid and open the orbit fissure, and then patient 2 days in the hospital. This is not a very long and a very difficult procedure, and the patient is then discharged to return for us to complete this treatment with stereotactic radiosurgery. In the case, we will complete this treatment with the cyber knife. The tumor is large. In this case, we treated this tumor and we had a recurrence later on. 5 to 6 years later, we had a decrease of the tumor. As you can see here, you have there the vertebral artery passing through it, and then we treated only this portion decreased in size, and then the tail of the tumor was necessary to be treated again later on. And this is in our experience of 20 years doing this. Now moving to acoustic neuroma, and I will go now a little bit fast because the concepts are already defined. We can see the facial nerve. We can see the relationship of these tumors quite well during surgery. This is a tractography that helps us immensely for us to maintain the function of the facial nerve in the patient. And this is here 1 week later, he's commemorating his nice surgery. You see quite well the trigeminal nerve, the relationship of the tumor. What do we want to do? We want to preserve function, right? We want to preserve hearing. We want to avoid death, preserve facial function. This is extremely important for these patients, and avoid morbidity and keep the patient at work. And radiosurgery does that to the patient. So these patients here suffer immensely because of the palsy. Patients want to have a nice and beautiful figure to be able to treat and to have security in life, in his job, in his school. Now, these tumors are classified in 4. This is a Kuss classification: inside of the canal, outside of the canal, touching the brainstem, and now compressing the brainstem. So these are the difficult ones, right? These are perfectly treated with stereotactic radiosurgery, and we will have contention that surgery also treats this quite well. Now, as you can see in the results here, it's microsurgery or stereotactic radiosurgery. Microsurgery doesn't cure the patient. There is a lot of recurrences in these patients that we treated later on. It can cure, but in many situations doesn't, and the facial paresis here can be high. So you now discuss with you that here, for instance, grade 4, 12% preservation of the facial function. So this is extremely important in terms of quality of life for these patients. These are the challenging tumors. In these tumors, large tumors, 4 centimeters, this is a small tumor. Large tumor in the hands of Dr. Sami, one of the most famous neurosurgeons operating acoustic neuromas. And you see that indeed, facial preservation, 21% function. Now you can do 90% preservation of the facial nerve, but not of its function. Its function you lose in 21% of the time. And here we have a 43% in the large tumors. Now it's a very almost 60% loss of function. Hearing, you can say the same thing. When they are small, you can preserve more, and you are in the 60%. When they are larger, you preserve much less, and you lose much more when the tumors are grade 4 of CUS. These are patients that we look at quality of life treated with stereotactic radiosurgery at UCLA, and comparing the quality of life of the patients with the quality of life of the population in Los Angeles in general. And then we can see here it is quite identical. In these patients, the quality of life. This explains why subtotal resection, which is completing with radiosurgery, or adaptive hybrid surgery, that's increasing because now we can also offer stereotactic radiosurgery. And we have here total resection in United States falling over time just because the complications are high and patients do not accept the complication. Adaptive surgery with radiosurgery is very important. Positioning the patient in 3 dimensions at the table allows us to see where the sinus is quite well and preserve function with high technology, see what we are doing over time, and resecting as much as possible, maintaining function, and already planning the stereotactic radiosurgery during the operation. So this shows here how radiosurgery has increased in the United States over time, and resection has decreased for acoustic neuroma, and radiosurgery increase in general for all tumors in general. You see that long-term surgery in red will have complaints from the patient more than the other 2 techniques of stereotactic radiation and radiosurgery. Examples, here is a young man that we follow for 17 years already. He got married during this time. He had a partial resected tumor. We treated stereotactic radiosurgery, and we followed over time. Here is his family. He didn't have a family then. He married, he has these 2 kids, and he is smiling and taking care of his family quite well. His wife is happy, the children are happy, and that's what we want when we treat a tumor. Here's an old lady that had been operated on, showing to you that recurrence do exist, and this was a complete resection. She had a paralysis of the face, but had a recurrence of the tumor. So he lost the face, she lost the facial, and over more than that, she had also a recurrence. So we treated this. Cyst is not a problem. The tumor decreased in size in 2 years, and she was having a good quality of life then. We see the nerves, we plan knowing where the cochlea is, we can preserve the function, the semicircular canals as well, and we can see these nerves nowadays using proper MRI. This is the Fiesta-Cis technique, and you see cochlea, we see the semicircular canal, and you go preserve the function of these structures quite well. Here in preservation, in our group of patients at UCLA was at the intern of 92% in the follow-up. This because we are looking very carefully at the distance of this tumor of the most important structures. Here you have the distance from the cochlea, right? We have quite well the vision here where we are. We can then, as we said, look at the hearing preservation. This is a meta-analysis, and you see that it's really in turn of 70% independent of age, large size or not. So the large size are a little bit less, but you can see that the results are quite robust and persistent. Cutting the tumor away from the nerve becomes extremely difficult. So we have preservation of these nerves is difficult, and anastomosis worse you cannot get a perfect function. So partial resection makes the patient quite happy. We don't need to make the neurosurgeon happy. We need to make the patients happy. And this partial resection, you make a patient happy. This is one of our patients here in Brazil, where we did a partial resection. So this can be extremely criticized by the ones that believe that you have to remove this tumor completely. But here is where the facial nerve is passing through. And we stimulate here during surgery, and we have facial response. We touched here, and the facial evoked potential tells us that the facial is here. So why resect this? To give the patient a facial paralysis? No, we don't resect this, and we maintain this, and we treat this with radiosurgery in the future. And here it is, 4 years later, we treat him with stereotactic radiosurgery. The tumor was quite well controlled, and he is in vacation with his family that grew over these years, already teenagers, and wife happy, family happy. Excellent result in this patient. Here, a patient operated on twice, in 97 and 2003, and the second operation, 2006. And here we have radiosurgery performed in 13, and the tumor decreasing in size, right? 14. So you see that the tumor responded quite well to the treatment. The radiosurgery was done. And here we have the response in 2016. Now, if you move on here, now with the outcomes, so you see the outcomes at intern of 97% in acoustic neuroma. It's high, the control rate. In these tumors, 3% we will need some other form of treatment. And we look at meta-analysis. The meta-analysis, what it shows, and we are looking here at complication. We know that grade 2 and grade 3 to grade 1 to grade 3, we can treat quite well, while grade 4, we can discuss partial surgery plus radiosurgery. In reality, hearing preservation, when you do a meta-analysis in general, we got this kind of data. Facial function more than 5% would be the maximum reported in the literature loss. And the trigeminal function, we have also reported very good results. Pituitary adenomas, and I will go very fast here. This is a way more complex pathology. It's not only a tumor, but also secretion. So what we cannot accept anymore, it's conventional radiation therapy, because in this particular patient of ours, this patient had conventional radiation therapy, follow-up of 31 years, radiation done in Germany, it followed in the United States, and we have here an ependymoma, an arteriovenous malformation of cavernous angioma, a meningioma, and this patient really died of this ependymoma. So radiation at long term in patients that fractions of radiation at long term that will leave, can do have tumors, and in this case, we have to take care of not irradiating the whole area of the brain, but being very focal to it, right? What we see in pituitary adenomas, they are very common tumors. 15 or 20% of the intracranial tumors, prolactinomas more than growth secreting tumors, more than ACTH, and more than TSH, non-secreting, way more common. The secreting, we have this distribution here. Prolactinomas then the most common, right? We can no longer accept the radiation in this manner. The goals at the control of the tumor, avoid impairment of vision, acquire normal endocrine function, and preserve mental function of the patient. It's close to the temporal lobes. We control over the production of hormones is extremely important in the secreting one. Medications first, surgery, and then complement with stereotactic radiosurgery. Recurrence of previous tumor, we have an indication, and treatment of tumors in surgery, inaccessible areas like hypothalamus and cavernous sinus. Radiosurgery can help these patients. So the there is no really a full contraindication on the treatment, and it's indicated in the patients that cannot have surgery. Surgery is not a cure. Microadenomas and macroadenomas. Micro, it's better than macroadenoma in terms of secretion suppression in acromegaly. And radiosurgery can help these patients after, these are the recurrent ones, the ones that surgery didn't help. We have in the literature from 17 to 100% control of growth factors. Now, prolactinomas. Prolactinomas, we can are the tumors less treated with radiosurgery. They are well treated with medication. Right? There's several medications to treat prolactinomas with good result. So when they don't respond, then they will be the case of treating with radiosurgery. TNTS failures do happen and happen in many patients, and those will need stereotactic radiosurgery, and I will reveal our own data on that. But in the literature, we see that a complete cure, it's between 11 and 62% reported. So 62 is quite good in patients that are very refractory to medication and surgery. Cushing's disease is even more difficult, right? 90% of them are microadenomas, many times very difficult to find the residual tumor after a TNTS, and the macroadenomas, they have a failure that is quite frequent. The recurrence can happen, and the medication may fail to treat, and we have to go and give the maximum dose as possible to control these tumors. And reviewing our results, we will show to you that it's easier to control the non-secreting adenomas, and this we go beyond 90% in control rate of these tumors, so with a dose that doesn't need to be too high. And we know well the tolerance of these nerves in the cavernous sinus. We can get over 25 gray here. We still do only 8 gray, even though some people talk about give 12 gray, but they do report visual deficits. So we remain doing this now for the past 30 years, only 8 grays in the optic apparatus, 15 gray in the stalk to preserve pituitary function. Here an example, non-secreting pituitary adenoma operated in 1989. Again, in 1990, here's the recurrence. It was sent to us to stereotactic radiosurgery at UCLA. We did in 1991, and you see the patient decreasing, and she had her baby, and life went well after that. Reviewing patients at UCLA, this data that I collected long time ago, secreting tumors of 20, non-secreting tumors we treated with stereotactic radiosurgery and stereotactic radiotherapy, depending on the invasion of the optic apparatus. And you see here radiosurgery with 16 gray, stereotactic radiotherapy with 46, preserving visual function, and volumes are definitely larger in the tumors that are non-secreting and treated with fractions of radiation. Secreting tumors need high dose of single dose radiation. They do decrease in size, or decrease less in size, and maintain stable, and they can even disappear. Non-secreting tumors, they decrease in size less. You can stable a great majority, and some failures we have in these tumors. Decrease in size of the non-secreting and stable with stereotactic fractions of radiation. It does happen. And secreting tumors, those tumor control in 87%, that's in size, 83% in the non-secreting. Overall, the tumors are in 94% of control rate. Growth hormones, 100% control of remission. Prolactinomas, we have here the failure in 50% of them. In ACTH, we have a failure that is quite high. Complications, important to say that we do have panpituitarism in 3.9, but we lose other axes of the pituitary gland. And when we add this all out, we have in turn of 17% of a permanent loss of function, radiation necrosis temporal in the temporal lobe in one case, in a new meningioma in one case. So we do have some complications with this. But to conclude this lecture, I would say the patients are indeed making the decision of what they want. They want to look good. They want to be happy in life. They want to be able to work. And they are choosing the type of treatment that they want, because they know from Dr. Google what exists out there. MRI diagnosis is bringing us with patients without any deficits. They have symptoms that are very light or no symptoms at all, just a headache, and they come with a tumor, and then we have to treat them. And in the 21st century, they don't want to have deficits anymore. They know they can have treatments that will not have deficits. Radiosurgery is an inexpensive treatment if you compare with microsurgery and ICU and hospital admission. Our group at UCLA, the ones that worked with me over the years and helped immensely in the care of these patients, and also taught me a lot in terms of stereotactic radiosurgery. The group that you put together here at UCLA, here in Brazil, right? It's a large group of people that work together with us to treat these patients, from who we have to be very thankful. Technology is best quality as possible. And throughout Brazil, we have our collaborators, part of Neurosapiens, that we treat patients together. We share patients and discuss